As part of my project, I looked at provision of language concordant care to patients with limited English proficiency by bilingual nurses, and looked at factors that affect provision of such care to patients. With immigration increasing and movement of people within and between countries, the likelihood of experiencing language barriers while receiving care or providing care has augmented. We also know that nurses are responsible to provide care to patients regardless of their culture, religion, ethnic background or language. So we cannot really use that excuse that because we cannot understand patients' language, so we cannot really provide care to them. We are also aware that language barriers can have negative impact on people's ability to adhere to treatment regimes and follow up with their medications and other treatments, comprehension of their diagnosis and treatments, and ability to seek information. And all of these different factors affect and sometimes increase medical complications in their conditions. There is evidence available in relation to the effectiveness of interpretation, in use of interpreters and translators. There's also some evidence available which suggests language concordant care is effective and patients feel more satisfied and more cared for when it is practiced. However, evidence related to how do nurses feel about it and how do nurses feel about providing care to those patients, that doesn't really exist. And through my personal experience and observation in the UK and in NHS, though the NMC guidelines or any other guidelines doesn't really suggest that nurses should not talk to patients in their language, but the culture and the environment is such that nurses are not allowed to talk to patients in their language. So for this study, the data was collected through three different approaches. I reviewed interpretation and policy documents for 30 NHS Foundation Trust hospitals from England out of 155 hospitals. Individual interviews were conducted and 3 focus group discussions were also conducted. So altogether 59 nurses from different ethnic backgrounds participated in this study. All of these nurses were able to speak at least one more language, including over and above English. So the data was analyzed using a thematic analysis, and the findings of the study were then shared through a finding consolidation workshop with 26 individuals from various NHS Trust organizations with a remit to work on equality and diversity related issues. And the idea was to just get their views about if the findings make sense to them and how can we make those findings more practice focused and can use them in practice. So just to give you a little bit overview of the findings, in majority of in all organizations actually, telephone interpreters are preferred. Family, friends and staff are not allowed to be used as interpreters. Staff only those who have interpretation as part of their job description can interpret, and among all these 30 organizations, there were only 2 organizations which mentioned doctors, nurses or other healthcare professionals, registered healthcare professionals, that if they feel comfortable they can use their language skills to assess their patients or provide them care. Interestingly, none of the organizations seems to involve staff in the development or review of the interpretation policies, and especially there was no indication that registered healthcare professionals such as doctors, nurses were involved in those policies at all. This just suggests findings of the qualitative interviews, which is different themes which were identified. So basically, findings suggest that participants provided care to a diverse population which came from many different countries, many different language abilities, and where language was a barrier, it was quite difficult to provide care to those people. Participant also talked about working with interpreters, which was effective. However, there were various situations where it was not very effective. For example, if the person was under the influence of anesthesia, or sometimes medical interpreters did not really understand medical terminology, so therefore they could not really provide appropriate information to the patient. Impact of the policy was quite good on patients because obviously patients felt more satisfied and more cared for. However, due to the lack of clarity of policies and the role description, nurses were not always comfortable about their role. They were comfortable in using their language skills to provide care to their patients, but they were not sure if they can be subjected to repercussions because of doing that, and they felt that their colleagues and organization do not really support them in using their language skills. And these are different quotes which nurses explain, and one of them is very interesting. It says that it's complicated. In my area, which is post-operative recovery, it's not practical or useful to talk to a patient who is coming out of the effect of anesthesia via an interpreter. It just doesn't work. So lessons learned from it: bilingual nurses need to be competent and confident about their language skills in clinical context. So strategies such as talking about nurses' responsibility in clinical care and nurses' responsibilities as independent practitioners needs to be discussed, especially in induction courses, and provision of language concordant care can also be discussed at that time so that nurses feel a bit more confident about it. Nurses should be encouraged to provide feedback about the usefulness or lack of usefulness of the policies implemented in the trust. There is a need to review language and interpretation policies in different trusts, and there is a need to involve nurses and other healthcare professionals in the development and review of those policies. Further researchers needed to explore the perspective of patients as well as non-BME nurses, because there is a perception that they do not like BME nurses to talk to patients in their own language, but why is it like that is something that we need to explore. So this slide just suggests the path which I've been through, from being aware of the problem to getting an award and trying to explore the issues to it. And today I'm here following completion of the project, disseminating findings, and journey hopefully begins here. I'm really grateful to all those who have contributed in this project in any way, shape or form. And my apologies if I've not been very clear enough, because I'm still jet lagged. Just came back from Canada this morning, presenting the same in a conference. Thank you.